numbers again, our hospitalization numbers are increasing. This has been a particularly bad week for Alabama schools. We've seen a huge increase in the number of cases in our school-age children this week. There were a total of 5,571 school-age children whose illness occurred during the week that ended August 21st. We don't necessarily know that those kids were in a classroom, or that they certainly don't know that they contracted it in a classroom, but among school-age children, that was the number of cases that were reported. Compared to this time a year ago, the same week, that's a 700% increase in the number of children who are infected. A 700% increase. As you know, many schools are struggling now with keeping the doors open. Many are going to virtual. We really want to be able to keep kids in school for face-to-face instruction, and yet it has to be done safely as well. The most important ways to keep our schools open are to vaccinate all those people who are eligible, those kids who are age 12 and up, all those faculty and staff and other educators working in schools. Universal masking by all people in schools, regardless of vaccination status, is also very important. As you know, when masks are worn universally and when at least 3 feet of spacing is maintained, people who are exposed are not considered close contacts, and those kids can remain in the classroom setting. This does not mean that you can mask one kid but not another kid. That is not universal masking. We want to be very clear on that. Just because one child has a mask on doesn't mean that they are not a close contact if they're exposed to someone who's unmasked and who's infected. So I think we've been very clear about that. Certain locations have taken a lot of liberty with trying to reinterpret that, but we are recommending universal masking for all kids and for all people in school, period. Finally, we continue to ask our schools to help us in identifying those cases and getting them out of the classroom. A case, a person who's infected with COVID obviously does not need to be in the classroom setting. People who are close contacts do not need to be in the classroom setting. Children who have COVID patients in their home do not need to be coming to school if they're considered a close contact, as they probably are. Kids who are close contacts in the school setting to another case in the school setting need to be out of the classroom setting. We have been told that somehow our guidance is confusing on this. Our guidance is not confusing on this. Our guidance is crystal clear. We do not need cases or close contacts in the classroom setting, or we will continue to see these thousands of cases each week like we've seen during the past week. We are going to go live with our K through 12 dashboard today. Our team has worked really hard around the clock to try to get that up. It is still based on some incomplete data at this time. We don't have all the schools reporting yet. We've been working very closely with the schools on being able to submit their data like they did last year, but by the time this press conference is over, in fact maybe now already, I believe that dashboard is live. We are considering this a test week of the dashboard, so you'll see that there's some big incomplete areas on there, but it's important for us to get that up as quickly as possible so that people can see what's going on in their community. We had over 5,000 cases in Alabama reported to us just yesterday alone. Alabama's percent positive rate is over 23%, among the highest in the country. Our hospitalization numbers continue to increase. We were at almost 2,900 hospitalizations yesterday, 2,879. 45 of those were pediatric cases. At least 5 of those children were on ventilators as of yesterday that we know about. Our ICU bed capacity continues to be a net negative. Yesterday we had 40 more patients in the state of Alabama who were in hospitals in an ICU. 40 more than we have ICU beds. These are patients who were receiving care in an emergency department or in a hallway on a gurney or somewhere else where they're having to obtain critical care because we don't have enough ICU beds for them. The statewide ICU bed capacity is about 1,562 total beds, and we had 1,602 people in ICU beds yesterday. Our COVID deaths are increasing, as you might expect. As we've told you many times, deaths are the last number we see to go up. We had 50 deaths reported to us yesterday, and we've had double-digit numbers of deaths in the 30s and 40s, and sometimes as many as 50 for the last 2.5 to 3 weeks now. We have 2 morgue trailers that were moved into Mobile and Baldwin counties in the last couple of days. This is the first time during the pandemic we have had to activate those. The state of Alabama actually owns 4 portable morgue trailers. We have additional refrigerated trailers. These are typically held in case of a mass casualty event, for example, when a large number of bodies appear at one time. This is actually the situation that is happening in Alabama hospitals now. We have enough people dying in such numbers in these locations that there is no room to put these bodies, and so that's why we are moving these mobile morgues down there. We have received some help from the federal government in the form of a medical team, a health and medical task force that arrived in Baldwin County last weekend. This is this past weekend. That's a 14-person team that has been working at the hospital there. We expect another team to be coming this weekend to Dothan, to Houston County. This is approximately a 20-person team. We understand at this time it's going to be comprised of about 4 physicians, 14 nurses, and 2 respiratory techs. This team is actually from the U.S. Air Force. They are active DOD because there are simply not civilian resources out there for the feds to find. So they're actually using active DOD troops, and we're very, very grateful for that. These teams are being deployed for 2 weeks at a time. Obviously, we'll continue to try to renew that as long as it's necessary to do that. A team from HHS, an assessment team, is actually going to Dale Medical Center in the next little while to also assess that facility and see what resources can be brought there. We are really in a crisis situation. We've said that over and over for several weeks. We need people to understand that you yourself, if you're hearing these words, you're the person who can make a difference. You need to be responsible for your behavior. You need to do what it takes to not continue this situation. I don't know how much longer we're going to be able to do this. I want to give you some updates on the use of monoclonal antibodies. As you know, we've tried to talk recently a lot more about the use of monoclonal antibodies. Monoclonal antibodies are one of the things that we can do early on when a person's infected or even when a person's simply been exposed in order to prevent them from getting sick and requiring hospitalization. Monoclonal antibodies have been used in Alabama now since about November. We were one of the first states to use them and one of the states that used them in very high numbers, certainly early on. But as we've had an increasing number of patients, we've had an overwhelming demand for those as well. We have added a tab to our dashboard that shows the locations of where monoclonal antibodies have been shipped. This is essentially copying the information that the feds have on where these shipments go, and I just want to try to explain that so that people understand clearly the situation with monoclonals. Monoclonal antibodies are a medical treatment given by injection or infusion. It's prescribed by a doctor. It's not for every person. It's for a lot of people who are at high risk. A lot of people that we have in Alabama who are at very high risk for serious illness. And so we're listing these sites where these antibodies are located because people have asked us for that information. But these are not sites that, generally speaking, are just open to the public. We do not want people to show up looking for treatments there. They need to be evaluated by a physician or other provider and referred to these sites. In most cases, many of these sites may be medical practices or hospitals that are treating people within their own facility, within their own patient population, and not open to the public. For those who are seeking monoclonal antibodies who don't have a physician, many urgent cares are providing this service, and we would ask you to contact them and see what resources are available. But we'll continue to update this map so that people can see where these are located. We are trying to increase the number of providers who can do this. The Medical Association has been a great partner with us in reaching out to Alabama physicians. We've added a few dozen new providers just in the past week or so. Many of them are doing the subcutaneous injection or the injections under the skin, which are logistically a little easier and quicker than having to do an IV infusion. And so many of those are able to do those in an office setting. we are also exploring other ways to add other kinds of providers to that as well. We are working with a federal vendor who's currently negotiating with about 6 hospitals in the state to provide monoclonal infusion services for those facilities. That allows those facilities to stop using their own staff, and so monoclonals can be administered by this particular contractor. Those hospital employees can go back to doing the things that they normally do in the hospital. We have other vendors that have been in the state as well, and we're working with now to try to find locations for them to go. Additionally, the health and medical task force teams that we mentioned earlier have the ability to replace hospital staff who are doing monoclonal infusions as well in some cases, so that those hospital staff can go back to their normal hospital care. We think monoclonals are terrific. They prevent people, sometimes 60 or 70% successful in preventing high-risk people from going into the hospital. We encourage people to use them and want people to know about them. They are not a substitute for vaccination. I think sometimes there's a mixed message out there that COVID's not so serious, and even if you get it, you can just go get a monoclonal and everything will be fine. That is a bad message to put out there. We do not want to wait for people to get sick, particularly high-risk people, and then hope we're able to get them to a monoclonal and then hope that it works. Monoclonals are a great option for us to have, but they represent a secondary option. What we want is for people to be vaccinated. In as many cases as possible, we can avoid folks from getting infected in the first place so that monoclonals aren't necessary. Our numbers of vaccinations are continuing to improve. We are have one of the biggest jumps in the country just in terms of the percentage of people now coming in for vaccinations. We still trail most of the country in terms of the percentage of people who've actually received or completed their vaccinations. We've, as of last night, have about 2.2 million people who received at least one dose, about 1.74 million people who've completed the vaccine series. We still see only about 29% of Alabamians in the 12 to 17 age group, those adolescents and teens, have been vaccinated. We can do a lot better than that, and I would really call on parents in Alabama to please talk to your medical provider about vaccinating your child, your 12 through 17-year-old child. It's crucial that we get those kids vaccinated. If nothing else, the numbers we're seeing in school-aged kids hopefully will convince you the importance of doing that. We were very happy to see this week that the FDA finally approved the Pfizer vaccine. As you know, the Pfizer vaccine is fully approved for ages 16 and up. Remember, the original EUA was for age 16 and up. So the approval was for age 16 and up. It still is used under an emergency use authorization for that 12 to 15 age group. But this is a fully approved vaccine. We've heard people for months and months who've said their excuse for not getting vaccinated is that we don't have an approved vaccine. Well, we absolutely do have an approved vaccine. We don't have an approved monoclonal antibody infusion that operates under an EUA as well. And so it's ironic that some people are touting monoclonals as an alternative to vaccination when vaccines are now fully approved for those people age 16 and up. The mRNA vaccine, the Pfizer vaccine that is approved, is exactly the same vaccine that we have used all along. The first shot and second shot, as you know, are identical. For those additional shots or booster shots that we have been talking about, that will also be exactly the same product. It's identical in every way. So we would encourage people who have been waiting for an approved vaccine to please go get vaccinated as quickly as possible. There is more safety data on this vaccine than any drug or vaccine or medical product or anything that has ever been approved by the FDA. Over 300 million doses of this vaccine have been used around the world. There's never been any type of safety data available on anything like there is for this vaccine. This is a safe vaccine. It's highly effective, and we need people to get vaccinated as quickly as possible. Let's see, just a couple of other items before we go to questions. We still, at this point, have vaccines available in more than 1,400 locations. Vaccines are available widely everywhere across the state in multiple locations in every county in the state, in almost all cases without need for an appointment. Certainly same-day appointments are available even in those places that require appointments in most cases. We have had now a total of 15,360 breakthrough cases. These are people who were fully vaccinated who subsequently were found to be infected. So 15,360, that's out of about 1.74 million people that are fully vaccinated. So about 1.9% of people who are fully vaccinated have developed a breakthrough infection, which is not that much. Going back to April, when we had vaccines widely available, there have been a total of 1,230 COVID deaths. That number has really accelerated this month, but of the ones that we have confirmed and are counting, there have been 1,230 deaths since April 1st. Of that number, 108 of them, so around 9% of them have been in people who were fully vaccinated. In almost all cases, these were people who were elderly or had serious chronic health problems. So out of the 1.7 million people who were fully vaccinated, less than 0.01% have died due to COVID. So I think I'm going to pause right there and be glad to answer any questions. Yeah, let me go here first. Let me go there.
Go ahead.
Yeah, go ahead.
Could you talk about the emotion that you just displayed as you said you don't know how much longer we're going to be able to do this?
Well, so much of what we're seeing is preventable. We've worked on this for a year and a half. We have hospitals with nurses and doctors who've been doing this nonstop. And, we're seeing this because people don't want to get vaccinated. They don't want to change their behavior. They would rather have an argument about masks than have an argument about how do we keep our children safe, or how do we protect Alabama hospitals, or how do we, anyway, it's very frustrating for all of us. So. Yeah.
I had much the same question. Is it fair to say that you're as frustrated as you've ever been, or concerned about what's coming down the pike? Because it seems that way.
Yes.
Can you elaborate?
Yeah, I mean, we're intensely frustrated. The science on this, we learn things all the time. We modify our suggestions a little bit as the science changes, but overall, the principles haven't changed in a year and a half. We know this is a disease transmitted by the respiratory route. We know you can stop that with a highly effective and safe vaccine. We know you can prevent a lot of it by wearing masks and just being careful about who you're around. And we can't seem to get people to pay attention to that message. So yeah, we're extremely frustrated.
Dr. Harris.
Yeah.
I had a conversation with someone this week, very educated person, very successful person. I mentioned the number of pediatric cases. I mentioned the number of people in the hospital, and she goes, "Jeff, there's 5 million people in the state. That's not a lot of people." You get that kind of pushback. How do you get through to those kind of people that don't understand how that affects the healthcare system?
We know we usually have nowhere near that number of people in the hospital. I mean, you're right. That maybe doesn't sound like a lot of people, but if you're one of those 3,000 people in Alabama hospitals, it matters to you and it matters to your family. We don't normally have these kind of numbers. We have a net negative 40 ICU beds. That's not normal. That's never happened before. That's never happened before. So, I guess if you don't know someone personally, it's easy to dismiss it and pretend it's not going on, but it's really happening. Yeah.
A lot of schools that have mask orders did those on a temporary basis. They're going to be expiring in the next few weeks. Can you stress the advice to them on what to do with it?
Our guidance is not changing, until we see, additional recommendations from CDC or until the situation on the ground changes. Right now, we support and strongly encourage and recommend, and whatever word I can use, to try to get people to support universal masking in schools. That's the way that we keep kids in the classroom. That's how we reduce disease transmission. That's how we keep people safe. And we would encourage people to continue doing that. I understand that Alabamians are divided on that topic. There are people who just don't want to be told what to do, and there are people that somehow think masks are dangerous or something. I would be the first to admit, having a kid wear a mask is, not a situation we enjoy. Many kids may not like them. Some kids don't like them a whole lot. I totally understand that. But we have all got to pull together and be on the same team and do something to protect our most vulnerable people in the state, to protect our healthcare facilities in the state. I have a grandson who is in public schools here in Alabama. He's got to wear a mask to school. He doesn't like it either, but he does it. And we need people to just get on board and see the bigger picture here. The bigger picture is we don't have a good way out of this until we can change our behavior to stop the disease from being transmitted and until we get vaccinated. Otherwise, I don't know how long we're going to be sitting there having this conversation.
Dr. Harris, a couple questions from our viewers. If a person has COVID, should they or do they need to get the vaccine, and if so, when?
Yeah, so if someone's been previously infected with COVID, we do want them to get vaccinated as well. Now, probably they have antibodies on board that protect them for a while. It's probably not a rush to get them vaccinated, but we have so much vaccine available, there's also no reason to wait either. So people can get vaccinated at the same time they would be eligible to get any other kind of vaccination. When they're well, when they're not having fever, when they're no longer infectious, they can go get vaccinated. So, generally speaking, a person infected with COVID after about 10 days is no longer infectious as long as they don't have fever and they're improving. So they could get vaccinated on day 11 if they want to do that, and we want them to do that. People, the new narrative now about why you don't need to get vaccinated from the people who like to spread that misinformation is that if you've ever been infected, you have these natural antibodies on board and there's no reason to ever take a vaccine. That's absolutely false. We have thousands and thousands of people who've had multiple infections. We know that the most robust immune response people have occur in people who have been vaccinated who have been infected and then get vaccinated. So we strongly want people who have been previously infected to go ahead and get vaccinated as well.
And another question that we have is, can you get the flu vaccine or the flu shot and the COVID vaccine close together, far apart?
Yes, so there's no reason to wait between the COVID vaccine and any other vaccine. So you can get them on the same day if you want. Flu vaccines are becoming available right now. I think some of the chain pharmacies already have them, in fact. And we do want to remind people that flu season is coming, so you can get them on the same day at the same time.
Dr.
Yeah.
Harris, is there any more of an aggressive plan you all can implement, whether from this office, from the governor's office, to help get more people vaccinated, to kind of fight the spread of this virus? Is there anything else you can do?
That's a great question. I don't know what to tell you. I'd say we're open to suggestions on that. We feel like we've given people the very best information we can. We're not going to mandate that people go out and get the vaccine. At least the state of Alabama is not going to do that. Many private employers may do that, or there may be, organizations or events that have those kind of requirements. I think those requirements are a really good idea. But we don't know how to convince people to take good advice. If they, we understand people have made this some issue about personal choice, and, we respect people's personal choice, but, there's right choices and there's wrong choices, and if you're not getting vaccinated, you're making the wrong choice. And it doesn't just affect you, it affects everybody around you, and it affects your state, and it affects your hospital. It affects the kids going to your school. So we hope people will make the right choice.
Dr. Harris, you said you're not going to mandate that Alabama people go out and get vaccines, but what role do you think Alabama's vaccine passport law is playing in the spread right now?
Well, it doesn't make anybody's job easier. I think there's ways that businesses and colleges and schools and others are working to try to figure out how to negotiate that law. People certainly, clearly now in Alabama law, you can't be required to show your vaccination status in order to receive some service. But I think it's very reasonable, for example, if you're going to be in a crowd of people where others are at risk at some event or concert or whatever, you might need to either show your vaccination status or show a negative test, or at least agree to have a test if you don't want to show anything at all. So people certainly can't be compelled to show their vaccination status. That's what the law says. But I think there are ways that we can still protect people in spite of the law. Yeah.
The number on the dashboard for week 34 this week is 4,300. Last week it was 5,500. Is this 4,000 number, do you think that's low because of incomplete reporting, or do you think it's going to be?
What was that? I'm sorry. What number was that for? For number of what? Cases, deaths?
Yeah,
what?
Cases this week, 4,337 on the dashboard. that just went live.
Oh, I'm sorry. That's for the school dashboard. Okay, I'm sorry, Ken. I got you. Yeah, that number is definitely low. I think probably that number represents less than half of the schools that would normally report. So the number I gave you at the top of this conference had to do with cases we know of in school-age kids, and so we don't necessarily know, are those kids in school? Maybe those kids are home virtually. Maybe they're kids who, for whatever reason, aren't in a school setting. But those numbers are reported to us directly from the schools themselves, and we know that this week is a test week for that dashboard getting up and running, and it just doesn't have all the information.
Dr. Harris?
Do you have a number in front of you, I don't know, for the last 10 days for August of the number of suspected deaths, maybe in the last 2 weeks or so?
Number of suspected, you mean deaths that just haven't been confirmed so far? Is that what you mean?
Correct. Yes, that they're being worked on to be confirmed.
Yeah. So the answer is yes, I do. I'm not sure I have it handy right this second, but we'll certainly, if you'll get with Ryan, we'll certainly get you that number.
Dr.
Harris,
Yeah.
just last week we were asking you about the greatest need in the state right now, and you were saying that it's bodies in the hospital to help work and alleviate the strain. Is that still the greatest need? When you say we're in a crisis situation, what exactly is the greatest need in our state?
Yeah, that still is an extremely great need for us. We are working with staffing services to try to figure out if we can find a way to help bring additional staff into the state. We are working with these federal resources that we have. We mentioned a couple of teams that are here, but we're trying to bring additional ones into the state. Obviously we're trying to keep people out of hospitals altogether if possible through vaccination, or if not that, failing that, through monoclonal antibody infusions. But our nurses and doctors and respiratory therapists and people working in hospitals have been doing this for a year and a half, and they just can't do it forever. And we see requests for staffing all the time that are being submitted, and people trying to arrange ways to cover just this shift or cover this group of patients who are already in the hospital. It's really almost a minute-to-minute situation in a lot of cases, and again, it's just not a situation that can go on forever.
Well, when you say that, Dr. Harris, do you see an end in sight? I mean, is there any hope for these hospital workers right now with 3,000 plus patients? Yeah.
I mean, I think when I say we are trying to help them any way we can, again, by trying to engage temporary staffing where we can, by trying to engage federal resources where we can. I don't think, I don't think there's a really good outlook if the hospital numbers continue to increase. I mean, if you add even more patients on top of that, I don't know. I don't know how or if we'll be able to handle that situation.
Dr. Harris, when you talk about the monoclonal antibodies, this is not for everybody. At one point, you were sort of telling everybody, go get it. Tell us why it's not for everybody, only at risk, and how it needs to, and I guess the difference between the health injections there about the urgent care and the hospital.
Sure. I hope we weren't telling everybody to go get it, but this is a medication that's available for people that have either been a close contact or who are actually infected with COVID, and who also are at high risk for getting hospitalized or dying. So this is not for people who are already in the hospital. It's not for young, healthy people who don't have really high risk, for some other reason of ending up in the hospital or dying. But it's for people that do have those problems. So people that have, chronic health problems, people that are older. One of the high-risk conditions that puts you at risk for hospitalization is being overweight. A BMI of 25 or higher, which describes a lot of people in Alabama, and frankly describes me, puts you at risk for hospitalization or death if you are infected. So the criteria include a whole lot of Alabamians. They include many of us because we're just an unhealthy state at baseline. but they don't include everyone. There are a couple of routes you can give the drug. Until a few weeks ago, it was required that you give it through an IV infusion, and so, that's just like any other IV medication you may have ever had. Someone has to start an IV drip in a vein in your arm, typically, and the medication runs in over a certain amount of time, and then you have to be observed for a certain amount of time after the infusion is over. We do have the option now, instead of going through all those logistics and all those requirements for equipment, of just injecting it under the skin, the same way that you might get a TB skin test, or the same way you might have had allergy shots before, where it can be done in an office setting. Someone uses a needle to put it under your skin. It actually turns out to be, if you go that route, 4 injections that you get at one time, and then you have to be observed for an hour afterwards. So it's quicker than receiving an IV. It's 4 sticks with a needle, I guess, as opposed to 1 stick with a needle. So maybe your needle phobia determines which way you want to go. But ultimately, it's a decision your doctor needs to make, or your healthcare provider needs to make, as to whether you're a candidate for that, and that's the person who would send you to get that treatment.
Okay.
Operation. You guys been to South Alabama? Is that true? Or do you have any plan anything sort of some sort of monoclonal operation in the Birmingham area?
Alan, could you repeat that? I'm sorry, I didn't catch that.
My people were telling me they thought did you guys set up some sort of monoclonal clinic operation down in South Alabama to help with this?
Oh, yeah.
Demand down there. And do you have any sort of plan for Birmingham, or do you think we have enough up here to deal with them?
Yeah, at this time, the state of Alabama is not operating those clinics, is not operating any clinics, although we have worked with several contractors and have one in particular that's a vendor that recommended to us by HHS, by the feds, that's negotiating with several hospitals in Mobile County, and I think maybe Baldwin County, both of those counties. Anyway, I think there's 5 or 6 hospitals that they're working with. We had hoped to have that by the end of last week, but at this point it's just a negotiation between that company and those facilities. But their plan is to set up a large monoclonal infusion center in Mobile County, I believe was the last plan that I was briefed on. And that will take the burden off these other facilities that are trying to do it at their own facilities using their own staff. Is there anything additional on that, Jamie? Do you know?
Right. There's
Just one second, I've got a little more detail here. Go ahead.
Sorry, sir. So Dr. Harris is correct. There are 5 facilities we're looking at to try to bring this KPMG IV therapy team in, DCH, St. Vincent's in Birmingham, and also UAB. Flowers in Dothan, as Dr. Harris was mentioning, in the southeast area. Mobile is another location we're looking at. So they are working through a statement of work, and once they get all that ironed out, they'll sign a contract, and once the contract is signed, they'll be here within 2 weeks. Additionally, we sent some requests for resource information to the FEMA late last night to try to get sub-Q teams in here in 3 locations. Again, trying to get them in the Mobile area, Baldwin area, and then also in Dale County. So we're trying to get as much resources in as therapies as we can.
Thank you. Thanks. That was Jamie Durham, who you all know well, I think. Yeah.
Anecdotally from hospitals and OBs, that they're seeing a lot more pregnant women and perhaps even more miscarriages in women who contract COVID while they're pregnant. Is the state doing any surveillance on that, keeping data?
Yeah, we're actually trying really hard to tease out that information. Our data team is working on pregnancy. It's not something we would always normally capture, but we're working on a way to do that. I don't know about rates of miscarriage. I'm not sure about that, but we do know just from reports from around the world that pregnant women are at a higher risk for serious illness than you would otherwise expect for young healthy women to be. That's not surprising because pregnancy is a relatively immunocompromising condition in a way. You see the same thing with flu, you see the same thing with chickenpox. Pregnant women just don't do as well with certain diseases. And that seems to be the case with COVID too. So we are trying really hard to collect that information, and we'll release it when we have it, but we just don't have it right now.
Why do we seem to be seeing more of that this time than we did earlier in the
I guess I would say I don't know that I don't know for sure that we did. I mean, again, we weren't specifically capturing that before. I didn't have reports of it before, and it may just be that, we're hearing about it because people are talking more about it, but probably it's because we have a much more highly infectious virus out there. Our older population are relatively protected because they're fairly well vaccinated. So we're seeing these thousands of cases again shift into a younger population, and that's, certainly might explain why you're seeing more pregnant people. That's just speculation.
Dr. Harris, you're talking about the monoclonal antibody treatment and how it's working to be expanded, but what will the cost be for people to try and get this treatment?
Yeah, there's not a cost to the person receiving that. So just like we've done with vaccinations, providers are able to bill, and there is a payment they can get from insurers or from the federal government for people who don't have insurance that'll cover the cost of that, but it's not a cost to patients.
Dr. Harris, is there anything else you can do within your power as the state health officer to get schools to implement mask mandates? I mean, are you having conversations with Dr. Mackey to say you need to do a statewide mask order for public schools? Or are you having conversations with Governor Ivey saying you need to say something about this? We're in a very serious situation. What else can you do within your power to make people wear masks?
I think, this is fairly similar to the discussion we had last week. I know everyone thinks it's a real simple thing. If I could just say you have to do it, then everyone would suddenly do it. But it's a very partisan issue. The state of Alabama is highly divided over it. Official after official from around the state has made it clear that they want those decisions to be made locally. The governor's been very clear there's not going to be a statewide mask mandate. So to answer your question about our conversations, we talk about those things all the time with Department of Education and with the governor's office about what our options are, what we feel like is within our ability to do. Ultimately, school boards also have the ability to do that, and many of them, probably more than half of them, have done that. It's not uncontroversial. It creates a lot of anger, and it creates a lot of unhappy people, and I think when you live in a democracy, that's absolutely got to be one of the things that you have to negotiate through when you're trying to impose something on people. I don't think we could possibly be more clear about what we think is the best way to protect people's health and to keep kids in school. I mean, universal masking is how we keep people from dying. It's how we keep kids from getting infected. It's how we keep our schools open. I don't know how to be more clear about that. Yeah.
An argument I hear a lot from people who haven't gotten vaccinated is that, oh, well, I'm in my teens, 20s, 30s, 40s, so therefore I'm at low risk. What is the message to those people, and what does the data show about the age of cases and hospitalizations now?
Yeah, so there's no question that people who are older are at more risk for serious illness or death than people who are younger, and so that's a reasonable calculation, I guess, in a way. But you have to remember, first of all, we're an incredibly unhealthy state. So if you're somebody with a BMI over 25, or if you have any type of chronic health problem at all, you are at high risk for hospitalization, and you're at high risk for dying. And that is a lot of Alabamians, including younger Alabamians. Secondly, your behavior affects other people. If you're a young, healthy person and you get COVID, odds are you'll do well, but what about your parents or your grandparents or the people you work with or the people you go to church with or the people you go to school with? You're going to be responsible for causing somebody else's hospitalization or somebody else's death. Ultimately, we don't want people to make a decision that could be seen as selfish. We want people to do the right thing, not only for themselves, but for everyone else. We have a fully approved vaccine. This is not some experiment, which is how the anti-vaccine people like to characterize it. This is a fully approved vaccine that has more safety data than any vaccine has ever had, and it's highly effective. It's free. It's available everywhere. You can go get it today, and then you don't have to make those arguments in your head anymore. You can go ahead and get vaccinated today. Ultimately, if we don't have enough people vaccinated, this will never go away. Please do your part.
Dr. Harris, this is second week of high school football. You mentioned 2-week period, 5,000, 5,500 people infected, kids. Not at school. What is your advice to those folks going to those games tonight?
Be careful. If you're a high-risk person, you don't need to be in a crowd of people who are from other households, particularly if you don't know their vaccination status, particularly if people aren't intending to mask or socially distance. It's whether you're talking about football or anything else, that's just not a safe situation to be in.
Dr. Harris, could you speak a little bit about, you've mentioned several times that we're really just at max capacity in our healthcare system, and you said you're not sure how much more we could take. I think, especially in the U.S., we've been privileged to not really know what it looks like, to not have healthcare sort of at our fingertips, or a lot of people have been. What would it look like if this does not go away, if patients continue to come to hospitals? Are we talking about triage and care situations, doctors having to make really hard decisions about who gets a ventilator? What is the reality there that y'all see if we continue down this path?
Yeah, I'll have to be honest and say I just don't know for sure, but it's clearly going to involve some of the things you're talking about. I mean, there's a point where there's just not any more room in the building, and even if you had staff, even if you had ventilators, you can only put so many people in a fixed space, and so we certainly have plans if we had to shift to alternative care sites, for example, truly, facilities that are built up sort of from the ground up away from a traditional hospital setting. That's always a last option. There are many reasons you want to try to take care of people within the four walls of the hospital building as opposed to going to another location. We would certainly, entertain that if it became necessary. I'll say, though, that there's only so many resources in the country, and if we're dealing with that situation, we probably wouldn't be the only state dealing with that situation. So again, it's these sort of what-if questions are very frightening, but there's a real simple solution. We all have the ability to prevent it. Just go get vaccinated, wear your mask, and we won't have to worry about that situation. Yeah.
You said our deaths were running about 50 a day now. I think at the peak of the pandemic, they were 80, 90, 100. You said at one point you didn't think we would get to that level because the most vulnerable people are vaccinated. Do you still think that?
Well, apparently I was wrong on that. I think we had 50 yesterday. I don't know that we're having 50 per day. I think we had 50 yesterday. I think the day before that, there were a couple of days that we didn't have any reported, but we had over 100 after a couple of days of not having any reported. So I don't think we're at 50 per day, but, it looks like, looking back over the past week or two, we're in the 30 to 40 range per day, something like that. I think the max we had back in January was, like you said, 70 or 80, although I think that was only one day we were that high, but we were fairly consistently over 50 for a while. We certainly hoped we wouldn't see that again, given the number of people who are vaccinated. But, remember, we're almost dealing with a different disease now. The Delta variant is so highly infectious that this isn't the same, it's not an apples-to-apples comparison to what we were seeing in January.
The refrigerator trucks going to Baldwin, is that correct?
Yeah, I believe one's in Baldwin and one's in Mobile. Is that right? Yeah.
Did we do that? I'm sorry if I missed this. Did we do that before, earlier in the pandemic, and
No,
not to be
we did not do that
directed?
before.
Why do we need to do that?
But it was a request from the coroner. They are the ones that assess that situation and ask for help when they need it.
Dr. Harris, can you talk about the state's plan for booster shots? I know they're about to be available soon, so is there anything to keep track of who's going to get those?
Yeah, so booster shots, we started talking about that last week after the White House made that announcement last Tuesday, I think, or Wednesday or so. Booster shots are on a timetable to become available about September 20th, assuming FDA and then CDC sign off on the applications that have been submitted to do that. Practically speaking, they're happening now. I think we know of people who are going out and getting them. We are not giving those in public health because we don't have the guidance to do that at this time, but I think there probably are providers who are doing that. The best information we have right now is that that boosters are going to be recommended for people about 8 months after they got their second shot. So remember, the vaccines only got here the third week of December, and so there was nobody who even had a second shot until earlier mid-January. So there's almost nobody eligible for a booster shot at this point, But by September 20th, we will see. That'll be about 8 months after the first group of people were completing their series. So the data that we have seen indicates that it's a good recommendation. Antibody levels do tend to fall off with the 2 mRNA vaccines by about then. However, people do seem to be really protected against serious illness and hospitalization and death even at the 8-month period. So again, boosters are important. We're going to do those. We're going to use, at the moment, the plans are to continue using our existing provider network to do that. We don't know that if we'll have mass vaccination sites to do that or not, but there aren't plans to do that right now. But at the same time, that is not as important as getting people vaccinated the first time. Those people who haven't been vaccinated yet are the ones we really want to reach. Those are the ones at highest risk for hospitalization and death. J&J did submit some information this week. I don't know if it was a formal application or if they were just publicizing their information on booster dosing. It looks like they're going to probably try to get a recommendation to get booster doses after 6 months. Again, remember, J&J came out in, I think, March, and so there actually aren't any people who've had J&J for more than 6 months yet either. So, but I think they're probably going to end up applying for a 6-month booster schedule. So.
Dr. Harris, my people want to know, a hurricane is not targeting Baldwin County or Mobile. If it did go that way, what would be the decision of the health department in preparing and helping with that situation?
Well, our health departments, work on those kind of things routinely. Our staff here in the Center for Emergency Preparedness works with state EMA and with local officials down there, as do our local health departments in Mobile County and Baldwin County, and for that matter, some of the other counties in the southern part of the state that aren't on the coast but still are fairly often involved in those things. We have already been in meetings about that. One of our responsibilities is when there's a need to open medical needs shelters. That's something that public health operates and staffs. If it's necessary to do that, we're very frequently involved in cleanup if there is a disaster in terms of tetanus teams and helping restaurants get back into business safely if there's been power outages and those kind of things. It's just honestly, it's routine. In a way, routine public health work, or maybe I shouldn't say routine, but it's standard public health work that we do all the time. So we'll be prepared to do that if we need to.
Dr. Harris, just regarding deaths from COVID, I know ADPH used to do the characteristics and release that daily and is no longer doing that. So we don't know the age category of those who are dying. So can you kind of update that on a breakdown of the age group? And are you seeing any of these 5 to 17-year-olds die from COVID or any other young adults dying in the state?
Sure, I think I can give you that, but to my knowledge, we are still updating that, unless there's just something today. Do you have any?
Case character, it's just some of the graphics.
Oh, okay, yeah. I think the way we used to display that was on a graphic form, and we've just changed that to just sort of a little bar graph. I mean, it's listed by numbers, but tab 8. So Ryan is reminding me that it's actually tab 8 on the case and surveillance dashboard, and I think that'll answer the questions. By and large, there are not children who die from this very often. That is unusual, fortunately. But I guess we hear sometimes from people who shrug and go, kids don't die, so what's the big deal? But I just have to remind you, a lot of kids do get sick from this. Kids have ended up in the hospital. We have kids on ventilators today. There are many kids who suffer long-term consequences from COVID. Kids have the ability to infect other people as well. And even young, healthy kids who don't get that sick in a classroom setting have the potential for sending everybody home for a couple of weeks. So even when we don't see numbers of deaths in kids, thank goodness we don't, it's still a big problem when we have this many cases in our pediatric population. Okay. All right. Any other questions? Or all right.
I have one question. The 20-person federal team is being sent to Dothan, Alabama. Can you tell me what their roles are going to be? Are they going to be working alongside physicians at the hospitals, or what exactly are they going to be doing?
Yes, I'm going to ask Jamie Durham if he can answer that. He's been directly working with that group, and I believe he can give you those details.
Thank you, sir. That's an excellent question. Their ultimate goal is for ED decompression, so they walk in there and sort of kind of take over that role, if necessary, freeing up staff at the local hospital to do other things. However, when they hit the ground, if the hospital decides that might be used differently, they can make that adjustment. But the ultimate end goal is to do ED decompression. Did that answer your question?
Yes, and are they going to be at both of the regional hospitals, Southeast Health and Flowers Hospital?
No, ma'am. They're going to be focused at Southeast. It's a 20-person team, and what they do is they break up in 12-hour shifts. So they're going to they're there for a month to work 12-hour shifts, 10 in the morning, first 12, and 10 the second 12. No breaks, straight through. So that's why they sent it appears to be a large team, but they're broken up into two teams.
Gotcha, thank you.
Hey, my pleasure. Thank you, sir.
Thank you. All right, any final questions? Okay, thank you all for joining us.
My 41-year-old cousin, who's an anti-vaxxer, has COVID.
Oh, I'm sorry.
And her husband went